Hello, everybody, and welcome to today's Care Connection webinar. This free live webinar is for care partners and professional caregivers of individuals who are living with Alzheimer's disease and its related illnesses. My name is Molly Fogel from the Alzheimer's Foundation of America. I'm the Director of Education and Social Services here, and I'd like to thank everybody for joining us. Today we have a special guest speaker, Eric Hausman from DIFTA, the New York City Department for the Aging. He's an independent consultant specializing in Medicare education and training, and his topic will be an overview of Medicare. We are so happy to have him as our guest. Before he goes ahead and gets started with this great topic, I just want to orient you to a few different things that are happening with our webinar today. Just so you know, on your right-hand side control panel, you'll see a few different opportunities for you to receive your handouts, which is at the bottom portion. There's 3 handouts, including the slide deck that is attached for your review. You are all in listen-only mode, and so there's no opportunity to speak. However, we're happy to have your questions, and there will be a time for questions at the end of the presentation. On this right-hand side control panel, you'll see a tab that says questions. Just type in your questions and we'll make sure to get to them before we're finished. If we run out of time and your question does not get answered, you can always feel free to give us an email or a call here, and we can direct you to Eric and provide that information that you are looking for. So again, everyone's in listen-only mode. Questions can be typed in on the right-hand side panel. Handouts are also attached and provided on the right-hand side panel that says handouts. And so without further ado, Eric, whenever you're ready, just get started by telling us a little bit about yourself, and we'll go from there.
Okay, great. Thank you, Molly. As Molly said, I work as an independent consultant specializing in Medicare education and training. And I work here in New York State with the HICAP program. It's a HIICAP. And it's a network of counselors, mostly volunteers, that help people with Medicare. But for those that live outside of New York State, there's actually part of a larger national program. Nationally, it's known as the SHIP program, SHIP, the State Health Insurance Assistance Program, where anybody with questions on Medicare anywhere across the country can get in touch with a counselor. You can call the phone number on the back of your Medicare and You 2017 handbook to be directed to your local program, or you can call Medicare, 1-800-MEDICARE, and they can direct you to a local SHIP counselor. And today I'm going to talk about Medicare. And the main thing that I'm going to talk about today is about choices in the Medicare program. And for people with Medicare, especially those that live in some areas, they really have a lot of choices as to how to get their Medicare coverage. But basically, for everybody, it all boils down to 2 choices. So after I do the introduction to Medicare and talk about cost sharing, what you're responsible for as a person with Medicare to pay out of pocket, we're going to talk about those choices. And the 2 choices are either original traditional Medicare, as most people get their Medicare that way across the country. But if you're on original Medicare, we'll talk about these big gaps in coverage, deductibles, co-insurance, co-payments, amounts that come out of your pocket. So how do people fill in those gaps? Well, some people have other insurance besides Medicare from their own or their spouse's former employer or union plan that fills in all or most of those gaps. Other people with very limited income and resources might have Medicaid in addition to Medicare, in which case Medicaid fills the gaps. But most people don't have retiree coverage, and most people don't qualify for Medicaid. So what can they do? They might purchase a private Medigap, a Medicare supplement plan, like you may see advertised from AARP. That's one way to get your Medicare. The other way to get your Medicare is to join a Medicare Advantage plan, a Medicare health plan. And these are private plans contracted with the government to provide all of your Medicare benefits through their network of doctors and hospitals, through doctors and hospitals that participate, that accept that plan. If you're somebody that has Medicare, these are the companies that are mailing you so much information especially this time of year, for their plan options that they have for 2017. But whichever way you decide to go, whether it's original Medicare or it's a Medicare Advantage plan, you're entitled to Medicare Part D. That's the prescription drug coverage. If you're in a Medicare Advantage plan, HMO, PPO plan, your Part D drug coverage comes as part of that plan. If you're in original Medicare, you're able to purchase a separate standalone drug plan. And at the end today, I'm going to mention the Medicare savings programs. The Medicare savings programs are for people with limited income, and they help to pay the monthly Medicare Part B premium. So let's start from the top, though, and talk about what is Medicare. Well, Medicare is a federal health insurance program. Mostly it's for people that are age 65 and over, although some younger disabled people may also qualify for Medicare. And whenever I'm talking to people that are going to be new to Medicare, as so many people are nowadays, my first question to them is always, are you collecting Social Security? Because I know if they're collecting Social Security prior to their Medicare eligibility, they're going to be automatically enrolled in both Part A and Part B of Medicare. But for people that are not collecting Social Security, and of course this is becoming more common, because you know the full retirement age for Social Security, it's working its way up to age 67. More people are deciding to collect Social Security after 65. And if that's your situation, then you will not be automatically enrolled in Medicare. You will not. And unless you're still working or covered under a spouse who's still working past 65, you would want to enroll in Medicare when you're first eligible during the 7-month, what they call initial enrollment period, which includes the 3 months prior to the month you turn 65, the month you turn 65, and the 3 months after that. And if you enroll in Medicare in any of the 3 months prior to the month you turn 65, your Medicare coverage is effective the first of the month you turn 65. And for many people, that's their Medicare effective date, the first of the month they turn 65. So again, if you're somebody that's collecting a reduced Social Security benefit at 62 or 3 or 4, you don't need to worry about enrolling in Medicare. It's going to be automatic. A couple of months before 65, they'll send you that red, white, and blue Medicare card on the mail. And on the Medicare card, it shows you the 2 parts of Medicare. Medicare Part A is your hospital insurance, covers you if you ever need to be admitted to a hospital. Medicare Part B is your medical insurance, covers you mostly for doctor's services, outpatient services in the hospital. And I want to talk next about the cost in the Medicare program, starting with the Medicare Part B premium. Now, Medicare Part A, most everybody gets that for free, for no premium. But Part B, people pay for that. Now, last year, the Medicare Part B premium was a little over $100 a month. It was $104.90. This year, it went up to $121.80. But you know, most people with Medicare, they're still paying the same $104.90 they paid last year. That's because this year there was no Social Security cost of living adjustment. There was no COLA. There was no increase in people's Social Security checks from 2015 to 2016. And the way that impacts on the Part B premium is, luckily, the government has this protection where they do not allow a person's Social Security check to go down from one year to the next because of the increase in the premium. So if you're somebody that was collecting Social Security last year and you were paying $104.90 for your Part B last year, you continue to pay the same $104.90 for all this year. Because if they allowed your premium to go up, even if it was just a couple of dollars, your check would go down. And they don't do that. That's most people with Medicare. But somebody's paying that $121.80. You know who that is? The new people. So if you're somebody that's starting Part B this year, you're paying $121.80. Or maybe you're somebody that had Part B last year but not Social Security, right? You took Part B at 65, but Social Security, you're going to wait till 66, 67. For you, there was no Social Security check to protect from going down. So the premium went up. You pay that higher premium as well, $121.80. And then you know what's going to happen for next year? Next year, you may have heard, there will be a cost of living adjustment. But it's only going to be a really small one, 0.3%, not 3%, 0.3%. So the average check is going to go up about $4 or $5 next year. The premium, as you see on the slide, is going to be $134. Now, with $134 and you getting a $4 or $5 increase, that's not enough to cover the increase in the premium for anybody. So what's going to happen? Well, whatever increase you would have received, your premium will also go up by the same amount. And for most people, for the second year in a row, they're going to wind up with no net increase in their Social Security check. Because if their premium's going up $4 next year, if their check, if their Social Security benefit is going up $4, then their premium is also going up the same $4, and it'll be a wash for 2017 for most people with Medicare. I'm going to talk in more detail today about Medicare deductible and coinsurance, what it means when a doctor accepts assignment on a claim, and what the limiting charge is for doctors that don't. The advanced beneficiary notice, I'll mention what this is about if you're ever asked to sign this at the doctor's office. The therapy limit is the cap Medicare has on physical, speech, and occupational therapy. And then I'll mention what you're responsible for under Part A if you need to be admitted to a hospital. So starting with the Part B deductible, and this is going up for everybody next year. It's going to be $183. So that means the first $183 in covered medical expenses, that's your responsibility next year, unless you have other insurance to pay that for you. Once you meet the deductible, Medicare generally pays 80% of what they allow, and you're responsible for the other 20%. That's the Medicare coinsurance. But in order for you to really understand your responsibility under Part B, you need to understand about the concept of assignment. And that's on the next slide, and that's an important term for Medicare. What does it mean when a doctor accepts Medicare's assignment on a claim? Well, if your doctor agrees to accept assignment, that means that he or she agrees to accept whatever Medicare allows as payment in full. In that case, your responsibility is only any unmet portion of that $183 deductible next year, plus the 20% coinsurance. That's assignment. Now, if your doctor signs a participation agreement with Medicare, as most doctors have across the country, that means they agree to accept assignment 100% of the time on all claims for all people with Medicare. Doctors that are participating in Medicare, if you will, they sign that participation agreement, never bill above what Medicare allows for any of their services. If your doctor, though, does not sign that participation agreement, if they're non-participating, they can still be part of the Medicare program. But these non-participating doctors have a choice on each and every claim to accept assignment or not. And if you decide to see one of these doctors that does not participate in Medicare and they won't accept assignment on your particular claim, the doctor's not allowed to just charge whatever they want or just their usual fee. The federal government limits doctors who do not accept assignment to charging only up to an additional 15%, 15% above what Medicare allows. That's the federal, what they call limiting charge. And then the great thing about having Medicare Part D, it should never be necessary for you to file any claims with Medicare. Doctors by law are required to bill Medicare on your behalf. But what happens is when you see a doctor that accepts assignment, Medicare pays the doctor. When the doctor does not accept assignment, Medicare pays you. So if you decide to see one of those doctors that does not participate and they won't accept assignment on your claim, chances are they expect payment up front, up to that limiting charge, at most 15% above what Medicare allows. You'll pay the doctor will file a claim with Medicare will reimburse you 80% of what they allow. That's how the Medicare program works for people that are on original traditional Medicare. Something else important to be aware of is on the next slide, and that's the advanced beneficiary notice. And this deals with the issue of medical necessity with Medicare. Now, if Medicare ever denies the service as not medically necessary, you as the patient are not responsible. You are not responsible to pay for that service unless you have signed this advanced beneficiary notice form. And there's a specific form that doctors and labs should be required to use if they choose to use this at all. Because a lot of times, I know, especially the first time you go to a new doctor, they probably have you fill out this long intake form asking if you're allergic to this or that. And then on the bottom will be some sort of blanket waiver statement, something like, I agree to be responsible for services not covered by my insurance. That kind of blanket waiver for Medicare, it's not effective at all, not at all. It must be the specific advanced beneficiary notice form, which indicates the date of service, the exact service being done, and the reason the doctor feels it may not be covered by Medicare. If you decide to sign that form, what happens is the doctor will still bill Medicare. Medicare might actually pay the claim. They won't automatically deny it, but if they do deny it, you'll be responsible for up to the doctor's usual charge for that service. If you decide that you're not going to sign this notice, then the doctor will probably decide they're not going to provide the service. And you can understand why. because they don't want to be held liable for that service. So Medicare, with original Medicare, it's not a managed care program. You cannot get, nor do they provide prior authorization, pre-approval for services. The way that you would know in advance that a service may not be covered by Medicare is not Medicare telling you, but rather your doctor telling you through the use of this advanced beneficiary notice form. Now, this form does not apply to services that are excluded, that Medicare never covers, something like acupuncture or hearing aid or dentures. For those kind of things that Medicare never pays for, you're always liable. You don't need to sign a form, you're just liable. But if it's for a service that Medicare can cover, like an x-ray, let's say, or a visit to the chiropractor, but due to your particular condition or due to the frequency with which you have services, Medicare considers it not medically necessary, you're only liable if you have signed that particular form, the ABN form, prior to the service being done. And that's why it's so important if you're ever asked to sign that at the doctor's office. There is one service, though, where you actually do know what Medicare allows for the year, and that's on the next slide, and that's therapy. Therapy is the one service where Medicare has a dollar limit, a cap, on how much they allow for the year. Next year, Medicare will allow $1,980 for physical and speech therapy combined. They put those two together. A separate $1,980 cap for occupational therapy. That means $1,980 that Medicare allows next year, paid at 80%. It includes therapy done in a private therapist office. It could include therapy done in your home if you're not receiving Medicare-covered home health care. And it also includes therapy done in the outpatient department of a hospital. Now, although Medicare does have this cap, this limit, some people qualify for an exception to the cap. So Medicare gives the therapist a whole long list of exceptions. Some are for people that have more complicated conditions, or maybe you're somebody that had 2 courses of therapy in the same year for things that are completely unrelated. If you do qualify for an exception, your therapist knows, because your therapist is the one that tells Medicare whether you do or not. If you do, then Medicare can continue to pay for medically necessary therapy in excess of that $1,980 cap for the rest of 2017. Therapy is the only service where Medicare does have this dollar cap, this limit. Everything else with this exception is paid as medically necessary. So far we've been speaking about original traditional Medicare, and we've been speaking about Medicare Part B, medical insurance. But there's also very significant cost sharing involved for Part A, for hospitalization. So for next year, for a hospitalization of up to 60 days, Medicare pays everything but the deductible. It's going to be $1,316. If you're in the hospital beyond 60 days next year, for the 61st through the 90th day, you're responsible for a daily copayment. Next year, $329. That's per day, for days 61 through 90 in the hospital. If you think that's a lot. If you're in the hospital beyond 90 days next year, Medicare allows an additional 60, what they call lifetime reserve days, which you can use once during the lifetime of your Medicare coverage in any combination. But once you've used them, that's it. They're non-renewable. For those 60 lifetime reserve days next year, you're responsible for a daily copayment, $658. And again, that's per day for those additional 60 hospital days. If somebody's discharged from the hospital, but they're not ready to come home, they discharge them to a skilled nursing facility for rehab care. Medicare pays the first 20 days of care in a skilled nursing facility in full. The next 80 days next year, you're responsible for a daily copayment, $164.50 per day, days 21 through 100 in 2017 in the skilled nursing facility. Now, these Part A benefits, they're not a calendar year benefit like Medicare Part B. Part B is fairly simple. You know, you got one deductible, $183. Once you've met it, That's it. You're done for the year. But the Part A deductible, it's possible somebody may have to meet that more than once in a calendar year, because it's once per what they call a benefit period. And the key to understanding Part A is to know how the benefit periods run. A benefit period begins the very first day you go into the hospital, and it ends when you've been out of the hospital, out of the skilled nursing facility for a period of at least 60 consecutive days, at which point your benefits renew. They start again. So for instance, let's say you had to be admitted to the hospital in January next year for 5 days. Medicare is going to pay everything but the deductible, $13.16. But what if you have to go into a hospital later that month, or a different hospital later that month, or same condition, different condition, doesn't matter. Less than 60 days have gone by since you were discharged, so it's still the same benefit period. Medicare, you just pick up where you left off at day number 6 of your first 60 days of coverage, and you don't. You don't have to meet a new deductible. But what about instead of being readmitted later in January, what if you're readmitted 3, 4, 5, 6, 7 months later? Still the same calendar year, still 2017, but now it's a new benefit period. More than 60 days have gone by since your discharge. Your benefits renew, they start again. You're back to day number 1 of your first 60 days of coverage, and you have to meet a new deductible, $13.16. So I hope this will help to point out the importance of people having other insurance besides Medicare. Because for people that have Medicare only, as you can see, you could wind up paying a lot out of pocket, especially for hospitalization. And when we talk next about Medigap insurance, you'll see how that fills in very nicely here. And that's a big reason why somebody may want to purchase a Medigap or a Medicare supplement plan. So far we've been speaking about one way to get your Medicare. Original, traditional Medicare. And if you're on original Medicare, we spoke about the gaps in coverage, deductibles, co-insurance. Now let's talk about filling in the gaps. Some people have other insurance from their own or their spouse's former employer that fills in all or most of the gaps in coverage. Other people that have limited income and resources might have Medicaid in addition to Medicare, in which case Medicaid fills those gaps. But if you're somebody that does not have retiree coverage and your income's too high to qualify for Medicaid, you are the ones that might purchase a private Medigap or Medicare supplement plan. There are 10 standard plans that are available from sale today, ranging from plan letter A to plan letter N as in Nancy. And these Medigap plans, they all cover certain things. All Medigap plans cover you for days 61 through 90 in the hospital. Okay, that $329 per day next year, they all pay that. They all cover the 60 lifetime reserve days, that's $658 per day next year. And if you should exhaust all your Part A hospital benefits, most people don't get to that point, but some do. All the Medigap plans will cover you for an additional 365 days of inpatient hospital care. Most Medigap plans pay the Part A deductible, $13.16 deductible next year. Most Medigap plans pay the Part B coinsurance, the 20% coinsurance, and then other benefits vary from plan to plan. Let me tell you the most important thing to know about Medigap insurance, and that is that the benefits are standard. So different companies sell these plans, and they charge different amounts. But as long as it's the same letter plan, it's exactly the same coverage, exactly the same. So if somebody purchases Plan F from AARP and somebody else does from another insurance company like Mutual of Omaha, they may charge different rates for exactly the same coverage because, again, it's a standard benefit, and the same letter plan provides exactly the same coverage. Also, what's important to know about enrolling in Medigap insurance, here in New York State, it's very easy because in New York State, it's always open enrollment, and people can always purchase that have Part A and Part B a Medigap plan regardless of their age or health. But for people that live in other states, most other states, they are very dependent on the 6-month, you may have read about, open enrollment period. So you may read about 6 months from when you're first eligible for Medicare in which people cannot be denied a Medigap plan. After that first 6 months, companies can apply underwriting, and they may choose not to sell you a Medigap plan based on your health situation. Okay, in New York State, we have continuous open enrollment, it's not an issue, but in most other states, you have to be very wary of that first 6 months when anybody can buy a plan. And although there are exceptions where other people may be able to purchase a Medigap plan, after that first 6 months, the plans, again, may decide not to sell you a policy. Okay, it's very important if you live in New Jersey, if you live in most other states. In New York State, not an issue because, again, it's continuous open enrollment here. Now, although it may be able to enroll, what you might be subject to is a waiting period for pre-existing conditions of up to 6 months. Medicare itself has no waiting periods. Medicare covers you from day one, but the Medigap plan may not. However, if you've had prior insurance, such as another Medigap plan, a Medicare Advantage plan we'll talk about next, employer, retiree plan, COBRA even, as long as there's no break in coverage or a short break of less than 63 days from when that insurance ends and the Medigap plan begins, they'll credit that time towards the waiting period. So if somebody's been on some sort of retiree plan the last 10, 15 years, all of a sudden they lose that insurance, they buy a Medigap plan right away, they don't have to worry about pre-existing conditions. Again, they'll credit the time with the prior insurance towards meeting that waiting period. So far, again, I've been speaking about one way to get your Medicare, original, traditional Medicare. And for those on original Medicare, if they don't have retiree coverage and they don't have Medicaid, they might purchase a private Medigap or Medicare supplement plan. Now let's talk about the other way to get your Medicare, and that's join what they call a Medicare Advantage plan, a Medicare health plan. This is Part C of Medicare. Nobody calls it Part C, though. It's Medicare Advantage. And we said before, these are private plans that are contracted with Medicare to provide all of your benefits through their network of doctors and hospitals. Most everybody's eligible to join. All you need is to have Parts A and B of Medicare. You cannot have end-stage renal disease, kidney failure, but any other condition, not a problem. And you need to live in the service area of the plan. But for most people with Medicare, there are only certain times that they're able to sign up or switch their Medicare Advantage plan choice. So people with Medicare can sign up for a Medicare Advantage plan when they're first eligible and enrolled in Medicare Part A and Part B. If they don't, or maybe they did, but now they don't like the plan, they want to switch, most people have to wait till the annual election period. Just ended yesterday. It's every year from October 15th to December 7th. If you sign up for a plan between October 15th and December 7th, your new plan starts January 1. If you discover in January that you don't like this plan, there's actually a second enrollment period. It's really a disenrollment period. The first 45 days of each year, from January 1st through February 14th, anybody that's on a Medicare Advantage plan that's unhappy has one additional opportunity to switch to original Medicare. Not another Advantage plan, can't do that. Original, traditional Medicare. After February 14th, for most people with Medicare, whatever plan they're on, if they're on a plan at all, that's what they're going to have for the rest of the year. Now, it's important to remember when you join a Medicare Advantage plan, you're not giving up your Medicare benefits. These private plans are required to cover whatever Medicare covers. Plus, as an incentive to join, they will typically cover to a limited extent some services that Medicare does not pay for. So, for instance, they may provide limited coverage for things like dental, towards a vision, eyeglasses, towards a hearing aid. They may pay for gym membership for that person, all things not covered by Medicare. But what I think is the biggest incentive, especially in our area here in New York City and in other places around the country as well, is that their plan might not even be charging an additional premium. You might have access to one or more zero premium Medicare Advantage plans. Now, you're still going to be paying the Part B premium, the $120, $180, or whatever you're paying for Part B. I'm saying some Medicare Advantage plans do not charge an additional premium above that. And they include the Part D drug coverage, some of them, no premium. And that might be a very powerful incentive for somebody on the phone that maybe doesn't have retiree coverage, that doesn't have Medicaid, that doesn't want to pay $200 or more a month for the average Medigap plan. You may be very tempted to join a zero premium Medicare Advantage plan instead. But even if your plan has no premium or a very low premium, that doesn't mean that your plan has no other cost for you. Because it's going to cost you on the other end when you access care, usually in the form of a copayment. So when you go to the doctor, it might be $10 or $20, some plans up to $50 to see a specialist. If you're admitted to the hospital, you might have a daily copayment. Some plans in excess of $300 a day for the first 5 or so days in the hospital. If you're admitted to a skilled nursing facility for rehab care, you might have a daily copayment. And what I find is that when people join one of these plans, they probably know what it's going to cost them when they have to go to the doctor. I bet it's printed right on their card, $10, $25, but maybe they don't know what it's going to cost them if they have to go to the hospital or a skilled nursing facility. Because a lot of times, understandably, people are just not anticipating those kinds of needs when they first join a Medicare Advantage plan. And unlike Medigap insurance, where the benefits are standard, and Plan F is Plan F, regardless of who you get it from and how much you pay, Medicare Advantage plans are not standardized at all. And in many areas of the country, including New York City, you have very many Medicare Advantage plans to choose from. Okay? How can you narrow down your choice? I always tell people start with their doctors. If people have Medicare, have a doctor that they're committed to using, that they would not want to switch, like many people with Medicare do, ask at the doctor's office which plans they accept. They don't take every plan, I bet. Maybe they haven't even heard of every plan. Then amongst the 3 or 4 plans they do take, find out how those plans cover their prescription drug at their pharmacy of choice, because the drug costs may vary from plan to plan. That's the way to make a good, informed decision about which, if any, Medicare Advantage plan might be right for them. Something else to consider, and in fairness to the plans, although plans have copayments, most plans for most services, some plans co-insurance, a percentage out of pocket for certain services, it's not an unlimited amount that you're responsible for the year. All Medicare Advantage plans have a maximum out-of-pocket limit. You might have seen this abbreviated MOOP, M-O-O-P, not to exceed $6,700 in network. So if you have a plan with that limit and you go to the doctor, it's $30, that $30 goes towards the limit. If you're admitted to the hospital, it's $1,000, that $1,000 goes towards the limit. And if you reach that limit, 100% coverage for the rest of the year for all Part A and Part B, for all hospital and medical covered services. The trend is that most plans now have the very highest limit, the $6,700 limit, but there are plans that have a lot lower limits, which might be available in your area. So you might see plans with limits as low as $3,000 or $4,000. And that could be important for you if you're considering a Medicare Advantage plan and you're concerned about having high out-of-pocket costs for doctor and hospital services. You may want to choose a plan with a lower out-of-pocket limit to make your out-of-pocket costs more predictable and less over the course of the year. Most Medicare Advantage plans, I would say, are Medicare Advantage HMO plans, where with an HMO plan, unless it's an emergency, you're limited to doctors and hospitals that participate, that accept that plan. But it may be available in your area, companies that are offering Medicare Advantage PPO plans, Preferred Provider Organization plans, where with the PPO plan, they also have a network of doctors and hospitals, and if you use their providers, you'll pay whatever copayment the plan has. The big difference with the PPO, they allow you to go outside of their network. Doctors and hospitals that take Medicare, but not that particular plan. And it'll cost you more when you do, but it gives you more choice, more flexibility than does the stricter Medicare Advantage HMO plan. So far we've spoken about the 2 ways to get your Medicare. Original traditional Medicare, which might come along with a Medigap plan, or a Medicare Advantage plan. It's one or the other. And whichever way you decide to go, you're entitled to Medicare Part D. That's the prescription drug coverage. And for people that are on a Medicare Advantage plan, HMO, PPO plan, Part D is easy. You got to get it from the same plan. So if you're in a Medicare Advantage plan, you get everything. Part A hospital, Part B medical, Part D drug, all from the same plan. If instead you're on original traditional Medicare without a Medigap plan, you can purchase a separate standalone drug plan to go along with that, whether it's from AARP or from Humana or SilverScript or any one of a number of other companies that offers that. And these Medicare Part D plans each have their own formulary, their own list of covered drugs. So not every plan necessarily covers all of you or your client's medications. And they have their own network of participating pharmacies. So the pharmacy that you like to go to, maybe they don't take every single plan. So how can you compare when you have many plans to choose from? The only way people can honestly do that is by going to the Medicare website, medicare.gov, where they have this great plan finder search tool, where if you enter the names of your drugs, not just the names, but the dosage, the strength, the quantity, and then you select the pharmacy that you're going to use, that search tool will then compare every single plan that's available and rank them based on your individual needs, from least expensive to most expensive. And then realistically, you probably consider the first 3 plans or the first 6 plans. That's the way to make a good decision. If you're not comfortable using the website, call Medicare, 1-800-MEDICARE. They're open 24 hours a day, 7 days a week. They can help you to compare plans over the phone. I mentioned at the beginning the SHIP program, high cap in New York State, where we have counselors, and they do across the country, that are trained to help people to compare plans. Many pharmacies advertise they'll do that as well. They're all going to the same website to make the same comparison. And I tell people you can't just make this comparison once in your lifetime and think that you're done, because these plans can and do change every year. So everybody that's on a Medicare Advantage and or Part D plan, they get a notice from the plan in September about changes for next year. They update the website in October. And then you or somebody else needs to make that comparison again. And if you find there's a better plan for you for next year, the time to sign up is October 15th to December 7th for the plan to start January 1st. Now let me mention about some of the costs with Medicare Part D. Now besides a monthly premium that you may pay for the plan, plans can have a deductible. Next year, it could be up to $400. Some plans have a $400 deductible next year. Some have a lesser deductible. Some have zero deductible. $400 is the most it could be. Under the standard benefit, plans drug costs between $400 and $3,700 in drug cost, you're responsible for either a fixed copayment or up to 25% out of pocket. And now here's where we get to the donut hole, the coverage gap that you may have heard about or experienced yourself. For people next year that reach $3,700 in total drug costs, regardless of how much they paid out of pocket up to that point, that doesn't matter. When the total cost of the drugs gets to $3,700, coverage gap, donut hole. And at that point, people typically pay more out of pocket for their drugs until, for people with very high drug costs, they may reach the catastrophic coverage. The catastrophic coverage begins at the point that you pay close to $5,000 out of pocket, $4,950 to be exact. Not including your premium, but including everything else you pay. Deductible, co-insurance, copay, whatever you're paying during the coverage gap. If you reach that $4,950, you get to the catastrophic coverage, where at that point you'll pay the greater of either 5% of the cost of the drug or a small copayment. That's how the plans are structured, but in order for it to be meaningful for you, based on your drugs and your pharmacy, you need to go to that website and put in your information and get an estimate of your cost of your drugs under the different plans that are available every year in the fall for the following year. You know, we talked about the donut hole, the coverage gap, but there are some people with Medicare Part D who don't have a coverage gap. They don't have a donut hole. That's because these folks receive what they call extra help, the low-income subsidy. Sometimes you see this abbreviated LIS. And this is a subsidy the government provides to help people pay their Part D drug costs. Some people get this assistance automatically. If you have both Medicare and Medicaid, or you're on one of the Medicare savings programs that I'll talk about next and last, where the state pays your premium, then automatically you get full extra help with Part D, which means you can get a subsidy that'll pay your Part D plan premium and will reduce your copayments to only small copayments. If you're not on Medicaid and you're not on a Medicare savings program, but you have limited income and limited resources as well, you won't get this assistance automatically, but you may be able to apply to Social Security for either a partial or a full subsidy. When you apply to Social Security, you could apply online on their website, Social Security or SSA.gov would be best. You can do that any time of the year. You need to have an income less than 150% of the federal poverty level. So to give you an idea, this year for a single person, figure about $1,500 a month. And limited resources as well, about $13,500, not much more than that for a single person. If your income and resources are above those amounts, you will not qualify for the subsidy, and you'll pay the full cost of the premium, the full cost of the drugs under the plan that you choose. Another great and very important benefit for people that get the extra help, even if it's only partial extra help, unlike most people who can only change their plans once a year between October 15th and December 7th, people with extra help can actually change their Part D plan, including a Medicare Advantage plan with Part D, anytime and as often as they want for their new plan to be effective the first of the following month. So if you know somebody with Medicare and Medicaid, they don't like their plan, they can be on a different plan January 1st, and another plan February 1st. They're not locked in at all. And in order to make that change, the easiest way to do so is just right over the phone with Medicare, 1-800-MEDICARE, 24/7. So the last thing I wanted to talk about today before answering some questions is the Medicare Savings Programs. The Medicare Savings Programs, for those that are eligible, it pays your Part B premium. Puts that $104.90 or whatever you're paying for Part B back in your Social Security check. If you know somebody today that has Part B and they're not paying a premium, they're already on the Medicare Savings Program. But if not, they may qualify. There are 3 Medicare Savings Programs. Let's talk about the one with the highest income level, the QI there, up to $13.57 a month for an individual, $18.23 a month for a couple. If you qualify for that or any of the other Medicare Savings Programs, not only does it pay your Part B premium, but it makes you automatically eligible for full extra help, okay? Which means, again, that you can get a subsidy that'll pay your Part D plan premium and reduce your copayments to only small copayments for your drugs. People can apply for the Medicare Savings Program at any time that they may be eligible, and you can apply regardless of whether you choose to get your Medicare through original traditional Medicare or you choose to get it through a Medicare Advantage managed care plan. So I know that was a lot of information. Let me spend the rest of the time today answering your questions. Thank you.
Absolutely. Thanks, Eric. So we have a lot of questions already, and as I mentioned at the beginning of the webinar, please make sure that you're typing in your questions on the right-hand side on the panel where it says questions. You can type in and we'll get to them as they come in. The first question we received was from Helen. Thanks so much, Helen. The question is, if the client gets CHHA, does that count towards the PT cap?
Right. So Certified Home Health Care Agency. So if you're getting home health care covered by Medicare, we're talking about original traditional Medicare. Medicare, at the same time you're getting home health care, they make one payment to the home health care agency. If you need physical therapy, they're not going to pay a private therapist at the same time that they're paying a home health care agency. So the home health care agency needs to arrange whatever therapy you need. That is not part of the cap. But if you have a therapist coming to your home and you don't get Medicare covered home health care, you just have the therapist, that's the same as if you went to the office. That is subject to the cap.
Excellent. Great. The next question from Vanessa. If someone re-enters the hospital a second time within the 60-day benefit period, I understand they are still covered within that benefit period. However, if a person re-enters the hospital a third time, let's say 10 days after their second visit, but 70 days since the first hospital visit, does the benefit period extend from the last hospital visit or strictly the first?
Okay. What you need to look at is the number of days from one discharge to the next admission. If it's less than 60 days, then it's the same benefit period. You just pick up where you left off. If it's more than 60 days, it's a new benefit period. You're back to day number 1 of your first 60 days of coverage, and you have to meet a new deductible.
Great. Okay, that's a really good question. Thank you for that question, and now we have some from Dawn. How does Medicare work if you are a veteran receiving benefits from the VA? If you have Medicare Part A but not Part B, can you enroll in Part B? If so, how does this work with the VA benefits?
Sure. So this is an important question for veterans that get coverage through the VA. Now, Medicare Part B medical insurance is voluntary. It's optional. However, if you don't sign up for Part B when you're first eligible during that 7-month initial enrollment period, and you are not still covered under your own or your spouse's active current employment at age 65, then if you want to enroll in Part B later, the only time you can do so is during what they call a general enrollment period, January through March of each year, in which case your Part B will be effective July 1, and you'll be subject to a late enrollment penalty. Okay? Now, veterans that get all their health care at the VA, sometimes what they decide to do is they decide not to enroll in Part B, understandably, because they feel they don't need the Part B coverage and they don't want to pay a premium for something they feel they don't need. Well, they're taking a chance, because if in the future they're going to need to use a provider that's outside of the VA system, they're going to need to wait, and they're going to be subject to the penalty. The only way around that is if they're a limited income and they qualify for the Medicare Savings Program. Because the Medicare Savings Program, not only does it pay your premium and eliminate any penalty that you might have, but if you're not already enrolled in Part B, it will enroll you into Part B as well, the same month your Medicare Savings Program is effective.
Okay, great. So continued questions from Dawn. If you have Medicare and are receiving VA benefits, which pays first?
Okay, if you have Medicare Part D, let's say, and you have the VA also, these work completely separately, okay? Where either for each service you receive, either you go to the VA facility and pay whatever copayment the VA has, if any, or you choose to see a private provider outside the VA and you pay whatever cost sharing Medicare has. Medicare does not supplement the VA and the VA does not supplement Medicare.
Okay. And the last question from Dawn, what is the max benefit for home health care services each year?
Well, home health care under original traditional Medicare, there's no set dollar amount or visit limit amount, but it is a very limited benefit. So in order to qualify for home health care, the most important thing to know is that you must have a need for skilled care. So if all the services that you need are help with bathing, dressing, activities of daily living that a home health aide can help you with, or a home attendant, Medicare is not paying for that at all. But if you have a skilled need, something that only a nurse can do or a therapist can do, then Medicare can pay for that unskilled care also in combination, but for a very limited number of hours. So if you look in the Medicare book, it might say up to 28 hours a week. More realistically, though, it's probably 8 to 10 hours a week or even less than that. But the home health care that Medicare does cover, it is covered in full, 100%. From a Medicare participating home health care agency. Again, if you have that need for home care, for skilled care, and you're considered to be homebound, which means that doesn't mean that you never leave the home, but it takes considerable taxing effort for you to leave the home.
Great. So thank you, Dawn, for those questions. Susie has a question. If someone under the age of 65 qualifies for Medicare through disability, but has a different BIN code or beneficiary identification number, will they be eligible for Part D?
Right. If you're Medicare eligible, it doesn't matter whether you're Medicare eligible due to age or you're Medicare eligible due to disability. You have a 7-month initial enrollment period in which you can sign up for a Medicare Part D drug plan. And it's the same 7-month initial enrollment period as surrounding Part B that we spoke about before. It's the 7 months surrounding the month of your eligibility. And if you sign up for a Part D plan during that time, it starts the first of the following month.
At this time, we have more questions available. If anybody else has questions, we've got about 10 more minutes to the discussion. So go ahead and type on in your questions. While you're typing in the questions, I'll let you know a little bit more about some of the resources that AFA can provide you. So AFA's national toll-free helpline is staffed only by licensed social workers and available to answer any questions you may have. Feel free to give us a call at 9 to 9 Monday through Friday, 9 to 1 on Saturday. These times are Eastern time. We're happy to help you via phone, chat, email, or Skype. We have our Dementia Care Professionals of America Training and Education Program. We provide classroom trainings and continuing education for social workers, as well as all healthcare professionals and paraprofessionals, as well as the family members and active seniors as well. We have our National Memory Screening Program, which provides free screenings to seniors or anyone really who's looking for a better understanding of where their cognition is today and to start that conversation about brain health and wellness. Our Care Connection webinar, which you are on right now, is held every single month. In 2017, we are planning some special edition webinars, which will offer continuing education for social workers, so please stay tuned for that. And again, we still have an opportunity for more questions. If you have any other questions, please feel free to type them in. We'll just give a few more moments as we wait for questions. As I had mentioned, we do have handouts at the bottom. You'll see the Quick Look for Medicare PDF, 2017 Medicare costs as well as the PowerPoint, all attached to the webinar. If you did not sign into the webinar and you are on the phone and you're interested in getting these handouts, please just make sure you give us a call or shoot us an email at info@alzfdn.org, and we'll be able to send these to you. So we have a few more questions. So thanks again, Dawn, for another question. Where can you find the calendar of upcoming monthly webinars? So you can find this on our website at www.alzfdn.org. The website has a tab at the top called Caregiving Resources, and in that tab there's a drop down and we'll talk about connecting, and that's where you can find it. We can also add you to our mailing list and you'll receive upcoming webinar schedules, which brings us to our next webinar, which is going to be in January, which I'll tell you about in just a moment. But I see another question. Thanks, Margaret, for the question. If one receives even QMB, does one get part, full, extra?
The extra help that looks like the Part D.
Yeah, thank you.
Right, sure. So if you get any of the Medicare savings programs, the QMB, the SLMB, the QI, any of those, automatically you qualify for full extra help, which with your Part D drug coverage, which means you get a subsidy from the government, which helps pay your Medicare Part D plan premium, and depending on which plan you're on, can pay the entire premium for you, and will reduce your copayments to only small copayments for covered drugs. That's true for anybody that has any of the Medicare savings programs and or Medicaid.
Fantastic. So thank you, Richard. We've got a question here from Richard. If you have if I have Blue Cross Blue Shield as a federal retiree and Medicare, can I still see a doctor who does not take Medicare? Can I still see that doctor and on my own just accept they don't take Medicare, but still submit under the federal program for Blue Cross and Blue Shield?
So that's really a question for your retiree coverage from Blue Cross to ask Blue Cross and Blue Shield. Some retiree plans only work like Medigap plans, where if Medicare doesn't pay, neither will the Medigap plan and neither will the retiree plan. But some retiree plans, because these plans are not standardized by the government, some retiree plans actually pay for services not covered by Medicare. And if Medicare does not pay for particular doctor services, you could ask, and you should ask the retiree plan, if they would still be able to. It's maybe yes, maybe no. It's the retiree plan to tell you that answer to that question.
Great, thank you, Eric, and thank you, Richard. So we have another question from Nina. Where do you find exactly what you pay for Medicare? Is this mailed out each year from the government?
Yeah, right, that's a good question to ask, and that's happening now for people that they're receiving a notice from Social Security, for those that are collecting Social Security, and it tells them what their benefit is going to be next year, and it also tells them what their Medicare Part B premium is going to be for 2017.
Excellent. Thank you so much. We still have a few more moments for questions. Well, while we're waiting for our last few questions of the day, I want to thank you, Eric, for the presentation. It was great to have you join us. I'd also like to thank all of you who are participating in today's webinar. We'd love to welcome you back, as I mentioned, for next month on January 12th in 2017 at 1 p.m. Eastern Time. We will have Bobby Matcher from Early Stage Alzheimer's Programs at the Duke Family Support Program in the Duke Center for Aging in Durham, North Carolina, discussing planning and preparing for early stage Alzheimer's disease. And so again, that'll be held next month, January 12th. Another question from Susie: Are there other statewide assistance for individuals that are not eligible for extra help but pay a lot for out-of-pocket expenses and need the additional assistance? Great question, Susie.
Yes. So some states, including New York State, have a state pharmaceutical assistance program, SPAP, SPAP, which in our state is the EPIC, EPIC program, that some people may qualify for, and it works kind of like as a supplement to your Part D drug coverage to help reduce what you pay. Most states do not have a program like that, but there are some states that do. Also, there are some copay assist charities that are available. Sometimes these charities may have certain requirements, the income, resources. Sometimes those copay assist charities like cancer care, for instance, you might have to have a certain particular diagnosis in order for them to assist you, but those are possible sources for assistance. Also, sometimes people may get assistance from the drug manufacturer themselves, where some manufacturer programs are only available for people that don't have Part D coverage or who don't have extra health. But other times, manufacturer programs may be available. So people can go to, I would recommend Needy Meds, needymeds.org for easier access. You can put in the drug name and see if there's a manufactured program that is available. Another resource for you, including information on the copay assist charities, might be and for any of your Medicare questions, is also the Medicare Rights Center. And if you don't know the Medicare Rights Center, they're a national advocacy organization. They're able to help you with the Medicare questions for both professionals and directly for people with Medicare anywhere in the United States. And their phone number, 800-333-4114, and their website, MedicareRights.org. They also have a very good website, if I can mention. It's Medicare Interactive, and the website is Medicare Interactive, written together, .org. And there you can enter your Medicare questions on a whole range of topics there, anything to do with Medicare-related insurance, anything we spoke about today, and more, and find much more information for those that like to do their own research. That's a great resource for answers to your Medicare questions.
Excellent. Great. Thank you so much. Those are fantastic resources.
You're welcome.
And so again, as we have a few more questions popping up here, thank you, Susie, again for those questions. Let's see here. So I think with all of that, we'll wait just another moment if anybody has a last-minute question that they'd like to put in. All right. Well, I'd like to thank you again, Eric, so much for having us listen in today. This has been fantastic. Very wonderful information and resources. Additionally, any other questions that you have for us or at AFA or for Eric, please feel free to give us a call at 866-232-8484. Our social workers are here to help you and here to answer any questions that you may have. We're also happy to provide any information you may need or relay information to Eric, who can also assist you. We can also be emailed at info@alzfdn.org. Again, any questions, we're happy to help you. Thank you all so much for joining us here today at Care Connection, and we hope you have a fantastic rest of your day. Thank you.